Inside the eye, advanced microvascular failure manifests as a sudden structural catastrophe. In an instant, a highly regulated capillary network violently ruptures, flooding the surrounding tissue with blood and plasma. Clinical models often frame type 2 diabetes and diabetic retinopathy as passive glucose dysregulation, a set of static numbers on a blood test. These diseases actually constitute an aggressive, interconnected systemic collapse, a cascading failure across metabolic, vascular, and neuroendocrine pathways. Standard medical responses are reactive. Procedures like focal laser photocoagulation attempt to halt the damage by intentionally burning away oxygen-starved retinal tissue to stabilize the remaining healthy cells. But stabilizing ischemic tissue is a temporary mechanical bridge. If the underlying biochemical cascades driving the disease remain intact, the damage routes around the surgical intervention, leading to irreversible blindness. This diagram isolates three critical interconnected nodes: the adipocyte-pancreas axis, the retinal microvasculature, and the neuroendocrine exposome. To arrest the disease, we have to trace the pathology from its cellular origins outward to the patient's daily external reality. Ignoring the psychological and environmental reality of the patient ensures the failure of even the most aggressive surgical interventions. This collapse begins with peripheral insulin resistance at the cellular level. The mechanical trigger is a caloric surplus combined with a sedentary lifestyle. This forces visceral fat cells to expand until they exceed their own vascular blood supply, starving themselves of oxygen and turning a hypoxic, bruised hue. These oxygen-starved adipocytes trigger a localized immune alarm, secreting pro-inflammatory cytokines like TNF-alpha and interleukin-6. These particles travel to and bind with receptor sites on adjacent muscle cells. Inside the muscle, these cytokines interfere with the intracellular insulin signaling cascade. Specifically, they inhibit the phosphorylation of the IRS1 pathway. Because the IRS1 pathway is blocked, GLUT4 transport proteins remain stranded in the cytoplasm. They cannot reach the cell membrane to open the gates, leaving glucose molecules to bounce off the exterior cell wall. This cellular blockade forces the pancreas to hypersecrete insulin. Over time, the extreme demand induces endoplasmic reticulum stress and the eventual death of the insulin-producing pancreatic B cells. Systemic glucose toxicity begins as a localized problem of oxygen starvation and mechanical expansion within visceral fat depots. Persistent circulating glucose eventually floods the delicate micro